Hello people. So open fractures are best explained through the classification. The mostly used and widely used classification is the Gustillo-Anderson classification, and it is an open fracture classification that concentrates on wound severity. It is not perfect, but it is very practical. It has actually three grades, and grade 1, grade 2, and grade 3 that subdivides into grade 3A, 3B, and 3C. And it is very good because it offers a prompt diagnosis in the clinical field, and then it points to the treatment. So when we go from the first stage, the first grade in this classification, so this would be the first. Here we have an open fracture, so the bone is fractured and it communicates through the skin to the outside. But the wound where the communication is less than 1 centimeter. So as we go up in the grade, the severity of the wound and the wound becomes more complicated, and the treatment becomes more complicated, and the risk for complications becomes higher. So in the first, we have an open wound with a very low amount and a low possibility of contamination, and the wound is less than 1 centimeter, and it is an open fracture. The second grade, we have an open fracture, so the bone fractured through the skin, and the opening is bigger than 1 centimeter, but less than 10 centimeter. So it is a wound that has a reasonable size, and there is no extensive soft tissue damage. So we have a bone fracture, a slightly bigger wound, and no extensive soft tissue damage. Of course, the wound is bigger than in stage 1, so contamination and the risk for contamination from the skin flora, especially in all of these, but especially in some smaller wounds, skin flora is our main concern. Then we come to this stage 3, where we have 3A is the first. So in the 3A, we have an open fracture, and all of these actually involve high energy trauma. In this high energy trauma, we have extensive soft tissue damage. So extensive So we have extensive soft tissue damage. The wound is bigger than 10 centimeters. It's a big wound. We have extensive damage, but in this 3A, the point is that we still have enough soft tissue, for coverage. So we have still enough soft tissue to cover the wound appropriately. Then we have 3B. In 3B, it is also extensive soft tissue damage, and these wounds often have a higher risk of contamination, and 3B is often said to be are wounds that are associated with massive contamination. And what is the difference to 3A? We don't have enough soft tissue, so we need further soft tissue. So the difference is, here we have also extensive soft tissue damage with massive contamination, but we need soft tissue, skin grafts, flaps to cover this wound. The 3C, the last stage of this third grade, is actually special because the main focus here is that we have a damaged arterial vessel. So it is an open fracture associated with an arterial injury requiring repair irrespective of the degree of the soft tissue injury. Most of the time we have also some significant soft tissue injury, but the main focus is that we have to repair a blood vessel. So injury, arterial, the key point in this is arterial injury. So these are the stages of this classification. The classification offers us, so if we take now a look, what are the principles of management of these open fractures? So the first important principle that this is the same for all of these stages, is a prompt diagnosis. So a prompt diagnosis can be achieved with this classification. We look at it, we see what is the wound severity, is there a pulse. We always check the pulse, the sensitivity, and the motor function, and then we have a possibility to grade the open fracture. After that, intravenous therapy appropriate IV therapy. So with that I mean antibiotics, so antibiotics and support therapy. So support therapy, we need to give the patient IV medication for pain and so on, for blood volume and so on. But the important thing are these antibiotics. We need to do an appropriate intravenous antibiotic, and because we are most of the time concerned with skin flora, cefazolin and gentamicin are often given as antibiotics to cover the skin flora. But this third step is the most important step in order to avoid infection and complication. This third step is debridement. So basically this means meticulous injury zone excision. So everything that once we see the wound, we need to clean it and remove all necrotic, all contaminated, all suspected and damaged tissues or foreign objects. Only if we do this correctly, all these intravenous therapy has a meaning. Then, of course, fracture stabilization. So fracture stabilization, it is known that if the fracture is stabilized, it helps the soft tissue to regenerate. So most of the fractures, especially the first and the second grade, can be fixed in the first operation, similarly to closed injuries, especially if we see that there is no big contamination, that there is no risk for infection, and if the wound edges can be closed without or with mild tension. Here we can, in the first act, do an open reduction and internal fixation with, for example, a plate. But in these cases, more of the time we need to do an external device, and when we are in the possibility, when we see that the wound is clean, that we can close it, and when we find when there is soft tissue and when we do a flap, then after that we can convert this external fixation into an fixation that is permanent, that will heal the fracture. Also here we have something that is called a second look. So if we have a big wound and if we are not sure that we eliminated all the necrotic and non-viable tissue, we can do a second look after 48 hours to again assess the wound. Also, with these big wounds that can have enough soft tissue coverage, we need to find a way with flaps and with graft to make this early soft tissue cover possible. But it is also important not to rush and to put a flap on maybe infected tissue, but preferably 5 to 7 days we should find a way to close it. Until it's not closed, there is a possibility to treat the wound with, for example, special dressings like VAC, vacuum assisted wound closure, that will also make the wound smaller. This vacuum assisted wound closure is good because it can make the wound smaller and it can promote healing. So also point, when this is done, the debridement, the surgeons take new clothes and they wrap the field again and then do these operations. And this is how most of these fractures are primarily treated. So a basic overview. Also, the Gastillo classification is a good classification, but for example, it doesn't tell in the first look sometimes much about the soft tissue injury. For example, it is mostly done for the lower extremity. But people who have, for example, an open fracture of the femur, and it only looks like this. So the wound, the femur bone broke, and the wound is only 1 centimeter, or it is 2 to 3 centimeters, so a first or second grade. But in order for the femur to break through all the muscle layers and the fascia and the skin, a high energy trauma needs to be working on the leg. So basically, people say that if we see that scenario, so for example, a big bone like the femur breaking and making an open fracture, that is always a 3A, because we have extensive soft tissue damage. So these are the shortcomings of this classification, but mostly because the possibility to assess and see the wound severity and to make a prompt diagnosis and staging, this is a nice classification that is widely used. Thank you.